Thank you, Lynn. Our next speaker is Abigail Fagan from University of Florida, who's going to share with us about her experience with communities that care.
Okay, thank you everybody for sticking around after lunch. I'm very privileged and honored to be here. And I want to build on some of the things that came out of this morning's session on community-based approaches and the rest of our panelists here and talk specifically about communities that care. It is a prevention system, not a program per se, and it is designed to build capacity of communities to do evidence-based prevention, no matter what particular behaviors communities are interested in preventing or healthy behaviors they're interested in promoting. And it's really a community-driven approach. And that's important because we know that communities differ in many ways, the actual problems that are going on, the factors that lead to these problem behaviors, the resources and capacity of a community, and what they value and what they want to change. And a one-size-all-fits approach may not be the best model. We want something that can be community-specific. And we also know, has been mentioned several times, that youth grow up in different contexts that have overlapping levels of influence, and that communities can have direct effects on kids' behaviors, and they can also affect these other contexts. And if you're doing interventions in families or with peer groups or in schools, if a community is not supportive of those prevention messages, it can definitely undermine the effectiveness of those things. So CTC emphasizes a really comprehensive and coordinated approach to prevention. And specifically, it relies on local practitioners and stakeholders to drive that process, to take ownership for what they want to see change in their community and to work together collaboratively to get there. And it also is very much driven by science and the use of science to assess the needs and behaviors in a community, to match those needs with evidence-based practices, and to make sure that those new practices are implemented with fidelity so that they can achieve their intended outcomes. So I'll talk more in detail about what CTC looks like. These are the 5 phases, and I will review some of those in the context of a randomized control study that tested the effectiveness of CTC in reducing delinquency, substance use, violence, and other problem behaviors. This study was led by David Hawkins at the University of Washington, and it took place in the 7 states that you see highlighted here. There were 24 communities randomly assigned to do CTC, that would be in 12 sites, or to do prevention as usual in the other 12 sites. So I'll be giving examples from our 12 CTC communities. These were located in mostly rural and suburban areas, and they were small to medium-sized towns, so from 1,500 to 40,000 population size, just to give you a little bit of the flavor of what these places looked like. Prior to getting involved in the study, and really in any community that wants to do CTC, we recommend that the key leaders in that community get behind the effort right from the get-go. So we had approval from the school superintendent, the police chief, and the local mayors of our towns who had to sign off and say, we're ready to do this. And that's important because they control some of the resources that are going to be needed to put prevention activities in place. But then they also help to create this larger coalition of stakeholders. And so I'm giving you here some information across the 12 CTC communities that we worked with, the representation from different sectors of the community that were involved. You'll see we definitely had a lot of participation from school officials, which was good because we anticipated some interventions happening in the school. But we certainly didn't want CTC to be a school-based approach. It's a larger approach where things can happen in the schools, and they should happen there, but we also want services being implemented in other agencies so that everybody has a role to play, and that also individuals in the community are also there to support those efforts. In the 3rd phase of CTC, the community collects information about the specific issues that it needs to address in their community. This is done primarily through a school-based survey called the Communities That Care Youth Survey, which can be done in middle and high schools. And youth self-report their exposure to risk factors and protective factors in various aspects of their lives: community, family, school, peer, and individual risk factors, as well as protective factors. And I wanted to just show you some real data that was collected from 8th graders in 2 of our sites. So you can see that what's happening in one community is not the same as what's happening in another community. So here, this coalition looked at their data and decided, well, we see some risk factors that are particularly high. In this case, about 50% of 8th graders consistently across several years of data collection were reporting elevated risks in these areas. But in another community, the profile, was quite different. Levels of risk factors were different, and what was being nominated most often was also different. So what happens after the coalition collects this data, takes a look at it, they use it to provide the foundation for their community action plan. What are we going to do to reduce these risk factors and increase our protective factors? And what is needed in one community is going to be different than what is needed in a different community. So the coalition as a whole looks at that data, and then they look at a menu of options that describes effective evidence-based prevention programs that have already been tested and shown to meet good evaluation criteria. When we started our intervention, we were using the CTC Prevention Strategies Guide. Now we recommend that communities use the Blueprints for Healthy Youth Development list of best practices. So just to show you, in these 2 communities, Community A decided they really wanted to focus on family-focused interventions, so they selected 2 family programs, 1 school-based intervention. In Community B, they had a little bit more of a range of programming, of a family-focused, a school-focused, and an after-school program. And in all of our other communities, this actual number and range of programs differed a little bit because it was up to the community coalition to decide, what do we want to do here? I also have to mention that while we had great representation from school officials on our coalitions, the schools were probably the hardest agency to break into as far as getting new programs adopted, for all the reasons we've been talking about. But eventually, over the 4 years that we were funding communities to do programs, all of them did adopt school programs. But it wasn't because our research staff at the University of Washington was saying, you really need to do Ulvaeus or some other school program. The coalitions made that happen on the ground, and the schools were partners in those efforts. So they were all looking at that data and determining, as a community, what can we do? As a school, we're part of this larger effort, and so that was very effective in leading to adoption of programs. We also emphasize very strongly in CTC that last phase, implementation, is critical. You don't want to spend all the time planning, adopting good programs if they get on the ground and they fall apart. So we emphasize the need to implement with Fidelity, and that this had to be done in a very systematic way that was being closely monitored. So again, the coalition has a role to play here. They help whatever agency is implementing a new program to monitor its implementation, to make sure that all implementers receive training in that new intervention, and that implementation processes are monitored. So implementers self-report how well they're delivering the curriculum. We also have observers from the coalition or the actual agencies who are implementing programs will send their administrators into classrooms or family-focused services to observe the quality of delivery of these programs, what they look like in practice. We also collect information on attendance and participation, and then very importantly, there's some quality assurance mechanisms. The coalitions review all that data and they look to see, what are we doing well, where have we deviated from our implementation standards? And if there are things that have gotten off track, they have conversations with the implementers and the agencies to see how they can get back to implementation fidelity. And that broad-based implementation monitoring system was not easy to implement. There was a lot of paperwork, a lot of moving parts, a lot of resistance on the ground. But the upshot was that we had high rates of implementation fidelity across the board, I'm happy to say. And this is just one little picture of implementation adherence. And it's a very crude measure. We just summarized across the different yellow school-based programs, orange after-school programs, blue parent training programs that were implemented by various communities over the 4 years we were studying them. By and large, they were delivering the majority of the material, 60, 70, 80, 90%. So we were very happy to see that, and we thought this monitoring system is what's keeping this going. This pressure from the coalitions emphasizing implementation, and then our outside pressure from the University of Washington to make sure that these things were happening as well. So those were experiences from this randomized trial across those 7 states. I also wanted to mention that in Pennsylvania, they have taken CTC to scale, and I'll give a big shout out to the state of Pennsylvania for funding CTC for the past couple of decades. They've funded coalitions to adopt the CTC model. They funded the replication of many, many evidence-based programs, specifically mostly those listed on blueprints. And they have also more recently funded the implementation of the Epicenter, which is a statewide center that helps provide technical assistance to coalitions across the state of Pennsylvania to assist them in carrying out this, somewhat complicated model to support healthy coalition functioning, to making sure that implementation of selected programs is going well on the ground, and to help support those efforts over time. So that has certainly helped the coalitions in Pennsylvania stay on course. The other neat thing about Pennsylvania is they have also emphasized fidelity in that to continue to receive funds for your coalition and your programs, you have to show that you're implementing them with fidelity, and you have to have the program developer come out on site and give you the stamp of approval. So again, some external monitoring certainly seems to help alongside having that coalition keep an eye on things. So kind of to summarize what we've learned from our randomized trial and from the work in Pennsylvania, and rather than give you a full-blown list of all the papers we've written, I will direct you both to the Blueprints website that has nice summaries of these papers, and in a minute to some other websites you can use. But we have shown that CTC definitely helps communities and agencies learn more about what works. What can we do? Well, here's a menu of options to think about. It definitely helps to increase support for the use of evidence-based approaches, including school-based programs, and establishing a coordinated array of prevention efforts. We know that the more you can target multiple risk and protective factors with multiple interventions, the more likely you are to see results in reducing problem behaviors, especially if you want to see this community-wide, and that's the goal of CTC, not just for an isolated group, but our entire community. How do we move that dial on bullying or related problem behaviors? We have also seen that in our CTC communities, they're implementing these programs both at higher numbers and with better levels of implementation fidelity, and that they're able to support those efforts over time. And importantly, that they are getting to the outcomes that they have set for themselves in terms of reducing problem behaviors. And I'll leave you with some of the just newly published results from our randomized trial in a paper by Dr. Hawkins and others. In our CTC communities, we found long-term improvements in having delayed the initiation of behaviors like alcohol use and delinquency. So these are the percentages of kids who report abstaining from alcohol use and abstaining from delinquent behaviors. More abstainers in CTC versus control communities. So those are good outcomes that we hope to continue to see as we follow the kids who've grown up in these communities over time. So again, if you want more information on CTC, there's a really cool website with new flashy videos that talk a lot about CTC, and you can feel free to contact me as well. Thank you.